everyone. Hope you're having a great day. He is Paul Gerard. I am, of course, Kevin Kelly. We are Gerard and Associates. Check us out at gerardassoc.com. This is the G&A Way podcast. Thank you for tuning in. Hey, Paul, it's great to be with you. I haven't seen you since the Fire EMS Pro Expo last month down at Foxwoods. How you doing, buddy?
Yeah, I'm doing well. Yeah, it's been a little bit of time since we've done our last podcast. The expo went really well. We had quite a few visitors, and it was actually a lot of fun. So those are always a good time.
Yeah, that was that was an eye-opening experience for me, retiring in 2005, but maintaining a connection through G&A and being the lawyer for G&A. But when I walked into that exhibition hall, it lasted longer than 4 hours, and I had to go to a doctor, if you know what I'm saying.
Mm-hmm. Yeah. No, I hear you. I mean, you definitely it had an impact on you. Your whole persona, you blossomed like a flower in the desert.
It's been 2 years, as you know, of some pretty significant medical issues. And, I'm trying to refine myself because my days of ever thinking about playing field paramedic again are long behind me. I just don't have the physical capabilities of doing that. So it was really about, okay, what's the next phase in the life of Criminal Defense Northampton, or Kevin Kelly, otherwise known as Criminal Defense Northampton, and the psychology that goes along with that.
Right. So nice segue, right? Because that's today's topic.
Yeah.
So along those lines.
Yeah. So, we at GNA and really, I think the CQI, or the patient safety, patient provider profession, often finds themselves in the role of trusted advisor, trusted counselor, and even to some degree, a therapist. And
Right.
we've had these conversations about the totality of what we see, what we do as paramedics or firefighters in the field, the cumulative effect on that, combined with what goes on outside of the employment that has a cumulative effect on us.
Correct.
And that kind of combines for this perfect storm, if you will, of opportunities to close holes in the Swiss cheese by better taking care of our firefighters and our paramedics and EMS providers. And we talk about this all the time, but your team sees itself in that role often. Isn't that right?
Yeah. That's one of the areas that we consider ourselves different, right? A lot of people, and we even had a podcast, we talked a little bit about the special sauce of GNA, right? Why are we successful when other folks sometimes have difficulties in getting providers to change behaviors and to improve their overall performance, their overall care. And we do a lot of things different, right? There's not one single answer. We have a really kind of cool scoring system that's an excellent tool to use. We created our own QA database that is unlike what people generally use for databases for QA. So we've analyzed every scope and aspect of how things happen on calls. So there's a lot of things we do different. But the one thing where the rubber hits the road, as far as I'm concerned, that makes up the majority of the special sauce is the connection between the CQI coordinator and the individual provider. Change happens right there at that spot. You can put up all the memos and notices, create all the policies you want. OEMS can come out with all the medical protocols in the world. If people aren't following them for some reason, you have to find out what that reason is. And historically in EMS, we have said, leave your personal life at the door. When it comes to patient care, everything else should be put aside. And while that's true in theory, in practice, providers are humans too, right? And we're affected by the stuff we see day in and day out. We're also affected by things that happen in our personal lives that may come into work with us. And we see it on the CQI side all the time when we talk with providers and start having the conversations. You wouldn't believe where those conversations go that have nothing to do with direct patient care when they're trying to explain why they did what they did.
Well, I can believe it. And I'll tell you why, because I was once one of them. And, I had to, at one point in time, focus on taking care of not just the patient, but the totality of that patient care scenario. And it's not just that one-on-one. You got family,
You're managing the scene. Yeah.
you got to manage the scene, you got the environment, all of that. And we have the amazing ability as EMS providers to separate that ourselves out for the most part and focus on saving that life.
Yeah.
And then, you get into the truck and, you start to do your paperwork, and then those voices in your head about what's going on at home and, all the other increasing concentric circle of issues that go on outside the Fire EMS Pro,
Right,
and
right.
how that creeps into your mindset and your thought process, right?
Yeah,
If
yeah.
you see me on social media, you see my tagline, thinking drives behavior. And in this particular case, in what we see, there's a lot of thinking that's driving a lot of behavior. And we have a unique opportunity, and your folks have a unique opportunity to help talk those folks down, get that amped upness down.
Right.
So can you give an example of maybe a conversation that's come up in the context of the CQI stuff that
Yeah. Oh, yeah. We see all sorts of stuff. I mean, we have everything from and the interesting thing is providers often don't know that they're allowing their emotional state to interfere with their practice until we sit down and go through the call with them. And when I say, hey, this is unlike you, you're normally on top of this sort of thing, what was going on that day? And if they are honest with you, and if you have a good relationship of trust with the provider, they will give you thoughtful answers as opposed to answers they think you want to hear. If they're afraid of you as a CQI person, that you're going to get them in trouble, they're not going to tell you some of the things that are going on in their personal life because they know they're not supposed to say that. Right.
Right.
So we've seen folks and talked to folks who are going through marital problems.
Yep.
And positive stuff too. I just had a kid, but I've been up all night for the last 3 weeks. I'm exhausted. Yeah. I got to come to work. I can't not come to work, but I got to take care of my kid too. We see people whose dogs have died, and that sounds crazy unless you're a pet owner and a pet lover, right? Yeah. The emotional toll that takes on you. Your partner was a jerk to you that day. Your captain or your shift commander brought you in and gave you shit right before sending you out on doing a call. Your medical director just called you in and told you the call you just did, you messed up, and then you get the bell rings and you go out on the next call. So there's all sorts of things that drive people to behave the way they do, and you can't help the provider unless you understand the provider, right? Seek first to understand, right? A Covey principle.
Right, yep.
And I would add to you've been getting a lot of hits on your social media regarding thinking drives behavior, but I would add to that emotional state drives behavior as well. And in a lot of these cases, that's what we're talking about. It's not what they're thinking. They're not consciously thinking of their marital problems in the middle of a cardiac arrest. Right. But emotionally, they're already triggered before that cardiac arrest comes in, and now they're hyper amped. Now they're even more stressed out. So I would add that. So yeah, there's all sorts of circumstances. Often the conversation starts with, hey, Kevin, we got this call, we got to go over, medical direction sent to us. They're asking why you didn't, fill in the blank, right? It could be any host of problems, but so, why you didn't do that. And often the provider will start out with trying to give a clinical rationale. Well, the patient didn't require, And then once you kind of poke a little bit of holes in that, right? And you say, well, okay, I understand that, but they still had a rather significant need as shown by the documentation, the report. The respiratory rate was elevated. Their SATs were terrible. You really probably should have used that CPAP on the patient. And you start going down the clinical answers. And after, for a lot of people, once they run out of their clinical justifications, then they kind of sit and they go, listen, I know I'm not supposed to, but this is what's going on. And I'll give you an example. To get back to you, give me an example. This happens all the time. We see it frequently.
Is this the ketamine? Is this the administration of ketamine?
No. We'll talk about that. Right. We'll talk about that too.
Okay.
But it's actually along those same lines, Kevin. It's actually the same principle. But you and I have been talking a lot about the ketamine stuff, articles in the paper. We'll get into that in a minute. But this is a case where, paramedic crew shows up on the scene of a cardiac arrest and they decide to extricate the patient out to the truck instead of performing ALS procedures and patient care resuscitation at the patient's side for a while. And that's taboo, right? We know there's plenty of literature. You got to treat at the patient's side, especially in the case of cardiac arrests. But this otherwise very good paramedic opted to extricate the patient out to the truck first. So I went and sat with him. We sat down, and he started with some of that stuff. Well, we were so close to the truck was right there, and those types of things. And we discussed it. And I said, listen, you're a smart guy. You know, the stuff I'm telling you is not new. You're well versed in literature and in your cardiac arrest care techniques and whatnot. What really happened? And he said, okay, I'll tell you. My captain, who's a basic EMT, who was on the call with me, is a scoop and screw mentality provider from years back. He hasn't worked as an EMT for years because he's been a captain, an officer.
Yep.
But he comes from the days of throw him in the truck, get going to the hospital and everybody.
Mm-hmm.
And I was working overtime on that shift with that guy. And he basically said, let's go. He was dragging the patient out the door. And I tried to say, hey, why don't we defibrillate him right here? And he said, nope, let's get him out to the truck. And it's my captain. He gave me basically an order to extricate first. So if you don't have a good enough relationship with the provider, there's not that trust, that bond between CQI coordinator and provider. You might not hear that, right? They're not going to tell you something that goes against management where you might go and tell that person, they might get in trouble. So you really have to develop that trust. So that's a clinical scenario. For an emotional, a therapist, the tone of this discussion is, CQI provider as therapists. We've had lots of cases where the provider says something along the lines of, listen, my wife yesterday, said she wants a divorce. The next morning I went in and went to work, and I was off all day. I've been off for weeks on this. I know I am. And so, how do you navigate that becomes the question.
Well, there's a lot there. How do you navigate that? This is what I think anyway, that we have got to develop, and it's not easy, but we've got to do. You've got to adapt to die, and we've got to work in this horribly complicated environment with other horribly complicated and flawed partners and medical directors and captains and chiefs. Right? We're all flawed human beings. It's progress, not perfection. So we got to figure out a way to we navigate that. And, how do you do it? You begin with the end in mind. I mean, you have to on all of these calls. And I think we do it more often than not. We do a good job. But you got to maintain that warrior mentality in that focus. And you get through the call. You got to do it. I mean, that's part of the job. There's no other option. Option two is you say, you know what? My head's not in the game. And perhaps I should take a day off and make sure that I go in peak performance. That's another option. But you know what? That's not our psychology, Paul. We don't like taking days off, especially the fire service.
Right.
So they
especially
don't.
Older providers. The younger providers are a little better about that. The older provider, because we came from, you could be half dead. You had to go in and fulfill your shift. That's your obligation.
Well, that's right.
And that's what we felt.
And if and you were held over,
right?
If you couldn't get coverage. And sometimes you were held over for 48 hours.
Right.
So now, and you and I worked on a truck that did sometimes 32 calls in a 24-hour shift. Not all of those were, workups, but I mean, that's a lot of running around with lights and sirens, with a lot of circulating epi and norepi. That whole Hans Selye general adaptation syndrome stuff.
Right.
So number one, figure out how to deal with it and try to deal with it. You got to adapt or die. It's in that Moneyball movie. Number two, take the day off. I think, we need rests. We don't like to do it, but recognize you're not in peak performance and, you got to take the day off. Three, you got to have a courageous conversation about that, at least on that particular call with the captain, because that's not the current state of pre-hospital care.
Right.
It's scoop and screw. I happen to like that. I wish we'd go back to that, quite frankly. But that's not my environment. I know you
disagree.
Yep, I know.
All about the patient care.
Yep. Well, the patient care can be done by nurses and doctors and not overworked and overstressed paramedics and firefighters.
Well, the nurses and doctors are overworked and overstressed as well. So you're bringing them to a similar environment. And the patient needs that defibrillation
Right.
now, not in 20
Yeah.
minutes when you get them to the hospital. And in,
Right.
in other cases, whether it's aspirin, so paramedic care in the street matters.
Yep.
And I think that we've gotten away from that scoop and screw mentality, which in most cases, not all cases, but in most cases, I think that's the correct way to go. As far as the call volume and all that sort of stuff, that's a bigger problem that has to be fixed on a bigger level,
Yeah. Yeah.
a different level.
But that is that captain EMT,
Right.
paramedic provider, that's a
Right.
relationship problem. That's an
Correct.
emotional bank account problem. And it starts above the captain.
Mm-hmm.
It starts at the whole mission, vision, organizational philosophy, and that includes understanding the statewide treatment protocols and where the state of transporting patients absolutely is. Nobody cares about what Kevin Kelly thinks. Yeah, Kevin Kelly, he wants to scoop and screw like the old days, probably like that captain.
Mm-hmm.
But that's not the state of affairs in EMS today.
Right.
It is the GNA way. And the GNA way is the statewide treatment protocols. And the statewide treatment protocols, and they're scientifically validated apparently because they're statewide treatment protocols, says you got to start treating on the scene. We have all of the tools and capabilities, the knowledge, the skill, the education to do everything that the emergency department can do in a patient's home. Mm-hmm. So the scoop and screw mentality, may be something that I would like to see for a variety of biases, by the way, because I totally agree with you. We have all of those. We can set up an emergency department in somebody's living room, and we can take care of the first hour of. I mean, they don't allow us to do it, but we can take care of right, because most of that is sitting around waiting for tests anyway.
Most of the right, when you're in the ER. Yeah, most of the basic, stabilization stuff we can do in the field, and it needs to be done in the field. Patients have better outcomes if it's done earlier for a lot of this stuff. So if not, there's no need for EMS, right? So if a patient can wait a half an hour to get their aspirin in the presence of their chest pain until they get to the hospital, then what do you need EMS for? Throw them in a cab, get them to the hospital. But good outcomes.
Not the way it is.
Result
not good patient care.
Right.
Not good provider safety.
Right. That's right. That's exactly right. So to get back to the, CQI officer's therapist, I think in a lot of these cases, providers try to give you some clinical justification for things that can't be clinically justified. And you have to be adept enough as a CQI person to see where that conversation's going and to say, all right, I got to dig a little deeper here because I know the provider knows better than this, right? So there's got to be something else driving their behavior,
right?
And get them, and sometimes it takes, even for us, we spend all of our time trying to gain the trust of the providers, right? That's what makes us different. We're not there just to drive protocol into their brains and to tell them that they violated this and they violated that. That doesn't work, right? That nomenclature, that verbiage, that just doesn't resonate with people very well. And in fact, they do the opposite. They tend to
get pissed
reject
off
and rebel. Yeah, exactly. They get pissed off. So really, we spend a good deal of our time trying to get to know the provider. And I can tell you, once we spent some time with them, a few months with them, we've gotten a chance to get to know them. We can tell you their kids' names, their dogs' names, their dog's last medical issue, because we start the conversation quite often with, hey, what's going on with you? And you get the standing, oh, nothing. Then when you get into the call and you start talking clinical stuff, and you start to divert away from that, when you're into your second or third call of talking with the provider, when you start diverting away from the clinical and getting a little bit into the personal stuff, that's when people start to feel comfortable and they feel like they can open up to you. So they'll tell you all sorts of stuff. They'll tell you about where they went on vacation, their current argument they had with their wife and who was at fault, why they think the chief's policy sucks in terms of a new policy that just came out the other day.
Right.
And they tell you all these things, but they'll only do that if they can trust you. And the really personal things, they have to trust you implicitly to know that it's not going to go anywhere. So we've had providers admit to us where they haven't admitted to their departments that they have medical issues. One provider was hard of hearing, and he kept getting his shortness of breath patients wrong. This is before the days of end title and stuff like that, but it's kind of a nice illustration. And, they were we were relying on, lung sounds to help us determine what's wrong with the patient, as one of our primary indicators of what the patient's condition was. And he kind of kept getting it wrong. And he's a very good paramedic. And after the third, fourth, or fifth set down of how come shortness of breath patients are your bugaboo? How come, you keep messing things up? They finally got to the point, and through the previous discussions, it was always something clinical, right? Well, I didn't think the patient was quite bad enough to use CPAP yet, or I gave him the first neb and he seemed good enough, and I elected not to give that second neb when I probably should have. And they try to use that clinical stuff. But then at one point, finally, he said to me, I'm hard of hearing, and I'm not sure if I'm hearing lung sounds correctly. He wasn't even sure. He was just coming to that realization. If nobody had given him that feedback about the other calls and discussed them and went through all of the clinical regimens of, the analysis clinically of the patient, what should have been done for him, he might not have even recognized this himself for quite some time. And he finally got to the point where he said, well, I'm having a hard time hearing stuff. Okay, that we can fix, right? There's stethoscopes that amplify, the sounds. You can make sure your partner does a secondary analysis of lung sounds for you just to make sure you're both on the same page. So there's things you can do. But he was afraid to say that because he was suspecting it. But he was afraid to go down that road and even get it confirmed because he was afraid that would impact his job. Because the management of that department was not, their attitude back then was, if you're damaged in some way, you're damaged goods, you're out of here. We don't want, folks who are perfectly fit and able type of stuff. So, and there's countless cases of that, people with all sorts of conditions, but they won't say that if they think that you're coming in with a leave your personal problems at the door attitude. Now, in reality, the expectation is we need you to be able to perform even when things are going on in your life, right? It's a true statement when people say that. But it appears to be an uncaring and unloving form of managing people. Whereas even if you just sit and listen, let them talk, and sometimes they feel better. Some of these problems we can't fix, right? Administratively, I can't fix a captain who's saying that unless I go to the chief or the provider goes above them, and we walk through all the scenarios, right? Do you have a relationship where you can talk with the captain about it and discuss it in a non-threatening manner? Nope, I don't have that. He's not even my captain. It's on a different group. Okay. So we go through all the different scenarios. Do you want me to get involved? Do you want me to talk to him? Do you want me to talk? No, because they'll get pissed that, I said something. So we go through all those iterations and try to come up with something that'll work. Ultimately, we got to get the provider to do the right thing, and they have to be able to work past their emotional baggage or whatever they bring into the job with them. But people do, on all levels, stand around a nursing station one night at 2 a.m. You're not hearing a lot of medicine being talked about.
That's
You're hearing
true.
all sorts of other stuff. It's not just us. You and I are hospital-based guys from years back, right?
I miss
we worked
those
in
days.
Hospitals. Yeah, I do too. Those are fun jobs. And even your ER physicians will sit and tell you about the personal issues that they're going through and whatnot. So we got to deal with it. We got to reckon with it.
Yeah, everybody knew everything about everybody, and it was all kept confidential.
Right.
There was some silent ribbing every now and then, but those were the good old days. Let me ask you this, Paul.
Yep.
How much of so thinking drives behavior, an effective, essential relationship, and we actually, it's the GNA way. The most important relationship in that EMS system is that of the CQI, teacher, coach, and mentor.
Yep.
And the mentee needing the teaching and coaching and the mentoring.
Right.
So so that's about trust. How much of the 4 C's, the GNA way, the 4 C's of successful EMS CQI coaches, how do you see that playing into your ability to gain the trust of these?
Yeah, it's the foundation, right? So if for folks who are not familiar, we've developed a theoretical construct of the 4 C's of EMS leadership and EMS CQI, right? CQI and leadership are quite interchangeable at any level. So we developed the 4 C's, and all 4 of those are applicable. But one of those speaks to the professionalism of the providers, right? So we've got stuff like compassion in there as one of the 4 C's, right? And so you and this is the irony. We expect our providers to show compassion to the patient, but our leaders sometimes don't show compassion to the providers when they feel like they're talking about stuff that they don't want to talk about. So we need to show our providers that same kind of love. So check out the 4Cs, gerardassociates.com. We got it on our website. You can read through it, but think through it in the context of this conversation as you're reading that, and hopefully you'll get something from that might be illuminating for you. But so we're reading all sorts of stuff online about how to take care of our employees, our providers, and that is being driven primarily from a point of view of we're losing providers exponentially at a rapid rate. People are leaving the profession. People are doing other things. And we need to take better care of our providers so that we can maintain providers and continue to provide care. That's kind of a selfish point of view, right? If you're a manager and you feel that you only need to enact policies to show your staff you love them so that they don't leave you, so you can keep your trucks on the road and keep generating cash for the service, as well as, keep doing your core mission of taking care of patients. While that is a decent intent, shouldn't we be taking care of our providers because we care for our coworkers, right? Shouldn't we be taking care of the mental, physical health of our providers because we care about them as individuals? That's the subtle difference between everything I'm reading in social media about why we should be taking care of our providers versus how management and CQI coordinators should be treating individuals on a day-to-day basis so that they actually enjoy the feedback, they respect the feedback, they realize it's helping make them the better provider, as opposed to the CQI guys are trying to get me in trouble. They're trying to bag me for doing something wrong. So it's a subtle but significant difference in the approach that we're taking to solve this problem.
Yeah, it goes back to the 4Cs: command presence, being compassionate,
right?
Having that competitive spirit. We want to be better tomorrow than we are today.
Correct.
But you got to be coachable. So those four things. And when you talk about the CQI leader being the therapist, and like you've shown me Rorschach tests. You've been my therapist for 30 years, and every Rorschach test you've ever shown me, what have I seen? The Star of Life.
Star of Life.
Right? So,
right.
But
well, once in a while you saw a mangled patient who rolled over.
That's true. That's where I got the PTSD from.
Right.
But with the therapist, the compassion, the 4Cs, that's recognizing that it's progress, not perfection. I mean, we got to remember that we're all flawed people.
Right.
And we got to be making progress. And the great thing about the unbiased scoring system is you got a jumping off point,
right,
to be better tomorrow than you are today. And no one's giving you crap about it because it's unbiased.
Right.
You're always in the moment during these one-on-one coaching sessions. This is what I hear routinely from folks that talk about GNA, that you have the courageous conversation, but you're doing it authentically. That's that trust and truth, but you're also doing it humanistically as well.
Right.
And that's through empathetic and active listening. And that pays dividends in that relationship building, in the building of what Dr. Stephen Covey called that emotional bank account, where, your CQI leader may have to make a withdrawal from that emotional bank account.
Right.
And, me as a paramedic, I have probably made some kind of withdrawal in my emotional bank account with my CQI leader. But, you got to have enough in the bank so you can make those withdrawals every once in a while without depleting that relationship and spiraling downward instead of upward.
Yeah. And you got to make it, if you're a CQI coordinator, you got to make it an integral part of your discussions with your providers, right? So what we do as coordinators generally is we read the report, we look up protocol, talk to the medical director, we go through all this analysis stuff and research, and we create a framework in our head. Okay, when I talked to Kevin about this call, the main issue is it took him 8 minutes to defibrillate that VFib patient. That's too long. There's no justification in the report for it. I need to bring home the point that he's got to do rapid defibrillations of cardiac arrest, identification of rapid defibrillation of cardiac arrest, right? That's the point.
Well,
and so when you walk into the room, we often start as that's our jumping point. Hey, Kevin, I want to talk about this patient you didn't defibrillate. And the problem is you've missed a great opportunity to understand what really is going on psychologically with that provider and why he or she may have made the choice they did. that can be identified before you even get into the clinical discussion if you preface that discussion with a, how you doing today, Kevin? How you been? What's new
Right.
with
Yeah.
you?
Yeah.
What's
Yeah.
going on? How's the wife? Is your
Right.
dog better? Is he still vomiting in the middle of the night, keeping you up? You know, and you talk about those
How did you
things in a
know that, by the way?
casual. I know everything. I
All
see
right.
all.
That's right.
I see all.
Okay.
Yeah. So the gospel according to Paul, right? Paul's view of the world is that you need to start when you talk with these people of a position of this person could be a great relationship between me and them, and together we can provide great patient care if I can get that person to recognize that I'm here to help them as opposed to I'm here to give them a hard time. And that goes beyond strictly the policies and procedures and the protocols. It goes to that humanistic element that we
Yeah.
routinely talk about, right? You have to humanize the CQI process to get people to understand that you really are there to help them and not to screw with them, in order for them to be honest and open so that they'll tell you what really went wrong with the call so that you can then fix it. If they're giving you bullshit answers to why they did what they did because they're afraid of you and they're afraid to get in trouble, you can't fix that, right? You're still left guessing what really was a problem, and you're left guessing with, well, I guess Kevin just is a fuck up because he didn't defibrillate that VFib patient, right? That's what
Right.
you're left with at the end if that person is not giving you good feedback that you can work with. And way too many CQI systems, they're striving for efficiency. I need to bang out as many of these audits and these reviews and these discussions as I can in my 8-hour day, as opposed to quality over quantity of CQI process. So it's the quality of the CQI process that's going to win over converts, not the quantity of calls that you process.
The number one thing the image that I get when folks talk about your staff teaching, coaching, and mentoring paramedics and EMTs is that it's done so in a way where you remain curious throughout versus judgmental, right? So you can start these conversations being judgmental. And that's what Kevin, and just the intonation and how you say Kevin.
Right. Exactly.
Right? You know?
Exactly.
And because I know, like when I hear my name, I know I'm either in trouble or there's going to be a teaching opportunity or I've done a good job.
Right,
one of those.
Right.
It's
just,
one of those
just
three things.
Tone,
just
even
the tone of
that
my
is
name.
body language. Even before that is body language. Just walking in the room or having a discussion with them. If you look uptight, it's going to make them uptight.
Yeah.
So you got to keep it loose. You got to keep it casual. Remember, what happened already happened. There's no changing that.
There's no changing.
So it's already happened. So now we just want to prevent it from happening again.
Yeah.
And that's only going to happen if you can have a good, honest dialogue with the provider. So your body language, the tone of your voice, the intonation, all that stuff, you have to monitor, and you have to, when you have this discussion, be in control of all that from the very moment. Even how you appoint your office can look very domineering and authoritative as opposed to a comfortable, casual atmosphere. So all of that stuff needs to be considered so that folks feel comfortable using the CQI folks as a resource and somebody to bounce ideas off. A lot of the people we work with, they'll call us up after a call and say, Paul, I fucked up this call bad. This is going to be terrible. Before I even write this up, I want to talk this through with you. To discuss what I need to make sure I accurately identify in my report, but without hanging myself, without me making a documentation error that's going to make things look worse.
You're a swing coach.
That's a swing coach. That's exactly where. They're Sherpa, right? They're spirit guides.
But that's I had a bat. We'll use Moneyball, right? You have a bat at bat, right?
Right.
You go into the dugout. You talk to the swing coach. What did you see? Well, I saw this, I saw that, your elbow wasn't up, your angle, your hand speed, you dropped the bat head too quickly, all of that stuff. And then you go in and you see it on replay, and you actually see what your swing coach is actually saying about your swing at that particular at-bat. Right. Now, the next at-bat, which would be akin to the next call, you have all of that swing coach stuff in your head, so you are making sure the angle of the bat, your hands, all of that, your grip, you're already thinking that on the next call.
Right.
And that's because the swing coach handled it in a way that was curious versus judgmental, and that decreased that post-traumatic stress of the CQI process.
Yeah. All right. So to keep running that analogy, if you strike out and you go into the dugout and you see your swing coach, if you say to the swing coach, "Where did I go wrong on this one? What's going on? What are you seeing?"
Hmm?
And you anticipate that the swing coach is going to say, "Listen, you lazy bastard, you're not in the batting cages enough. You need to get here early in the morning, get in the batting cage. That's your freaking problem."
Right.
Or say it in that tone.
Yeah.
You're not going to go back to the swing coach and ask for that advice, right? So, but if he says, "No, I'm watching you closely. You're lifting your head too quick. You're getting your eye off the ball too fast. Your follow through is not proper," and they present that to you in an analytical but approachable form, then you will go back and actually solicit that advice, right? You'll go back and say, "Tell me what I'm doing wrong here."
Yeah.
So it's really just human interaction 101. This is the way we should all be with everybody, right? Our spouses, our dog, our whatever, our accountant. You need to treat folks with respect.
Yeah.
Well, I didn't say our lawyers, right? Those guys
are accountants, right? Yeah.
Don't treat lawyers that way.
All right.
But in general, that's the way it should be.
Right. Yeah. It's remain curious versus judgmental.
Right.
Be about the 4 C's.
Yeah.
Have that command presence. There's nothing wrong with having a command presence.
Right.
You just can't be a dickhead about it.
Yeah, exactly.
Right?
You can present as an authoritative figure and still be approachable. Right. So just because you wear a lot of bars or bugles on your collar doesn't mean that you can't also be act in a humanistic fashion and be compassionate.
Right. And we've laid that all out in our 4 C's document that's on the website. But yeah, compassionate, empathetic listening. You got to be competitive too. We want to be better tomorrow than we are today. It's about quality improvement, but don't we want to be better than the next guy? I mean, don't we ultimately want our service to be considered a Hall of Fame service? I mean, that's kind of we want to be proud of. We want to be proud of the brand.
Right.
And in order to be proud of the brand, you got to understand that brand is made up of all these little EMTs and paramedics, and they all got to be marching in unison.
Right.
And they all got to be about the mission. They got to be about the vision. They got to be about the organizational philosophy.
Right.
And if you're not about that, then it's not going to work. The old saying is organizations are perfectly aligned to get the results that they get.
Right.
Well, if you're not really happy with your CQI program, you might want to think about some realignment and starting with being curious versus judgmental. Yeah. Paul, I know we gotta jump off. Is there anything else that you think we need to cover before?
No, I just really want to remind people, the CQI folks in particular, that when they need to look at their job, we are change agents, right? And you and I have talked about this, whether we should even say to people that we do CQI, because ultimately that's the byproduct of what we do. But really, we're change agents, right? Maybe we're something different than CQI, really, quite frankly. But that'd be a hard sell convincing people, that what we do is going to improve their patient care. But really, we're change agents, and change agent philosophy is you get people to change based on convincing, that as opposed to by brute force, right? So you got to win over people. So when you go into these dialogues, you want to analyze the clinical issues and implications, but really you should be thinking, I need to get inside the mind of this person and understand where they're coming from or where they were coming from on that day of that call, and understand what their predilections are for doing certain things in certain situations. Understand them well enough that I can give them good advice and counsel. And that's what you should be doing. You should be giving advice and counsel. It should be servant leadership, as opposed to, you screwed this up, don't do it again or you're in trouble. So go into it with the right frame of mind.
Yeah, servant leadership, modeling those behaviors that you expect others to model as well.
Correct. Yeah, you can't preach compassion. You weren't compassionate to that patient if you're not compassionate to the provider. So you have to walk the walk, walk the talk, actually, and make sure that what you're doing aligns with what you're asking your providers to do.
All right. I think that is sage advice from Paul Gerard and Associates. And that's it. thank you for listening. We hope you picked up a tip or two on the skill sets, the attributes that will help you become a better therapist, a better trusted advisor, a better teacher, coach, and mentor. And remember, we didn't get this right out of the starting gate as well. We made some mistakes along the way. But you got to care enough about filling in your personal holes in the Swiss cheese and becoming a better CQI coach.
Right.
So,
providers are people too.
Providers are people too. Well, that's it. Thanks so much for tuning in, everyone. And have a great day. Stay safe. Stay in the fight. And Godspeed. For Paul Gerard, we're out.
Talk to you soon.
On fire.